these days having laser machine, OCT and everything, and they have to do laser photocoagulation, and how to make the decisions of doing a laser, when and how, this will be discussed here in by the experts of Retina, and we'll be sharing our we have with us Professor Shrikant from BHU, myself, Dr. Kamaljeet Singh, then we have Abhishek Saran, who has not come, Dr. Pranav Saluja, Jivitesh Singh, and Dr. Divakant Mishra. They are all experts in retina, and they would be telling you the finer points and how to take decisions quickly. Dr. Shrikant, sir, please.
Thank you, Dr. Kamalji, for introducing the aspect. We are just doing some few modifications because Dr. Divakant Mishra has to go to some other session. So bear with us, because instead of missing him, it's better to have him as the first speaker. So he'll be, and now I invite Dr. Divakant Mishra. He'll be speaking. No doubt it will be become more relevant also. Prophylactic laser for pre-distressing lesions of retina tear. Dr. Divakant Mishra, he is the practicing vitreoretinal surgeon at Lucknow, being trained in vitreoretinal surgery from Shankara Eye Hospital, if I am not wrong.
And I'll tell you that his exam was taken by Professor Shrikant. MS exam, DNB exam was taken by Professor Shrikant.
Thank you, Dr. Kamalji, for kind words.
Keep on telling all my PGs that today it's not the cataract but medical retina which has become important, and it should be tackled by
I think he was very much involved with the development of or establishment of the laser photocoagulation facilities at the State Institute of Ophthalmology way back in 80s, in fact. We were having a Unitex xenon arc photocoagulator, then we upgraded to laser photocoagulator, and then LIO was also added, and recently they were the one they are having the Pascal lasers too. So he is, I think, right person who can give you a better introduction about the subject, the lasers. He has seen right from the beginning in development of the lasers. Dr. Kamalji, please.
आ नहीं रहा यार स्क्रीन. So you see, Professor Shrikant was my senior also, and I used to watch him doing fluorescein angiography. Then we were developing fluorescein angiography then there in Allahabad, and laser was not available, so there was xenon arc photocoagulator was available, and we used to do with that. Professor R.N. Mishra, my mentor, Dr. Shrikant, also my mentor. He went to Retina Associates for doing fellowship in Retina. So, and I was always in touch with him. So gradually, I was a xerophthalmia man. Gradually, I became laser in the year 1992, although I passed out in 1983. When this laser came, Professor R. Mishra, as you all can see, is sitting there, and Professor H.K. Tiwari from AIMS, Professor Azad, these two persons used to come, and there was no laser available anywhere in North India. Patients used to come from Calcutta to us. There was no laser available in Lucknow, Varanasi, anywhere laser was not there. So we started doing laser, and those days, we used to simply ask what is the full form of laser. So they used to tell light amplification by stimulated emission of radiation, that we used to ratify. वो उस समय पता नहीं होता था कि ये होता क्या है. So it's basically the gas through which the medium this goes, and it is stimulated, and the energy that is produced, that leads to a kind of laser, and depending on the gas, which the medium that is used, like argon, krypton, based on that we give the name to them. Now, how laser works, that is important to understand. So it basically goes, and the melanin in the retinal pigment epithelium and the hemoglobin, they absorb the laser photocoagulation, that is for the retina that we use. the blue-green laser that was available those days, and we used to hit the, apart from macula, we used to hit all over and do the laser. So it has direct action on the vessels, leading to closure and reduced leakage. This can be done, and it reduces the demand for oxygen. Like in proliferative diabetic retinopathy, you have hypoxia, which leads to formation of neovascularization. And when we do laser photocoagulation, we change the hypoxic areas into anoxic areas, and therefore the demand for oxygen is reduced and we have regression of the vessel. So that is there. Then there is a third theory, that is the RP activation following photocoagulation injury leads to cytokine production, and this ultimately leads to reduction of VEGF load, and therefore the vascularization becomes less. So this is another thing, and the edema is also then reduced. So this is what I told you. And the quality of the laser is that if you have a single columnated light laser beam, if you throw it from here, it will go up to the moon. But this the light that we see here, that cannot go beyond a certain distance. You cannot see that. So that was used for in the army initially, and gradually it was picked up by the scientists, and this was then used for ophthalmics use also, and variety of things. So based on the medium that we use, I have already discussed this. You can use it, and visible range is there, in which you have a blue-green laser, and this blue-green laser in gray, yellow. In this diagram, you have green and yellow. So this is around 488 and 514 was the wavelength that we used to use. The only problem is that if you go too close to the macula, the heat can dissipate into the fovea and can cause damage to the fovea. Therefore, we have to do laser photocoagulation in the peripheral portion of the macula. Maybe these days we go about 750 micron away from the fovea to do laser photocoagulation. So this is used, and nowadays we have a frequency double YAG laser. YAG laser's frequency that we used for YAG laser capsulotomy and iridotomy is 1016, and half of that is 532, which means that the double frequency YAG laser is, again, it's 532 wavelength, which is absorbed by the retinal pigment epithelium, and that is being used these days for laser photocoagulation. So its application in many diseases is there, which will be discussed by the experts very soon. You can use it in diabetic retinopathy, ARMD also it was used, glaucoma, cataract. There are so many uses of lasers that is being done, peripheral iridotomy, then cyclophotocoagulation. All these things are being done by laser photocoagulation, so it becomes non-invasive surgery and patient is very happy, and without any incision into the eye, you can do several procedures with laser photocoagulation. And there are many. In the past, we used to have a laser which had all kinds of wavelengths. So even in that, we could select the wavelength and then use that. For cornea, the wavelength is different. For retina, it's different. For the lens, it's different. And femtosecond, you have all seen these days, has come up again. So there are several indications which gradually they will tell us. There are certain modifications that have come these days, as we were discussing. The problem of the conventional laser that we have been using, even today we are using, that is that when it goes and hits the retinal pigment epithelium, it does not hit the RP only, it goes into the choroid also, and the heat dissipates into the surrounding area and the pigments. So the damage caused because of that, and the spots that are produced cause field defects. So that is the problem. We do PRP, and many a times too much of photocoagulation leads to optic atrophy also in many of the patients. And if you, by the way, hit the macula gets destroyed. So you have to be very careful in using this. Newer modifications are there, which is called semi-automatic laser delivery systems, like pattern scanning laser, in which you have 5x5 or 4x4, or depending on the thing that you choose, you can give several shots in one go. So that the time taken by the laser photocoagulation, although it's costlier than the usual one that we have, the time taken to perform the PRP, because you have to go 2000 to 2500 shots, it becomes much less. तो 25-25 शॉट अगर आप लगाएंगे चारों तरफ रेटिना में, तो इन वन गो यू कैन हिट 25 शॉट्स, तो या और भी बढ़ा सकते हैं आप. तो based on that you can do pan retinal photocoagulation very fast, and the patient does not have too much of botheration, because in doing laser photocoagulation with what we do, patient gets, after some time he gets tired and he gets pain also, so that becomes slightly problematic. So this Pascal method has come, which can help you. So this is an example of the shots that are given. Equidistant shots go and hit the retina. So the if you post-operatively, post-laser, if you examine the fundus, it looks beautiful more than what you have with a single shot technique that we have around. So that is called Pascal. And then now this micro pulse laser has also come, in which the because there are micro pulses in the pulse form, the laser comes, it comes and it produces heat and then cools off, and then again produces heat, then cools off, like you have pulse technique in the phacoemulsification, pulses are used there. तो उस तरह से इसमें what you do is that you have less of the heat into the pigment layer of the retina, and therefore the damage caused to the retina is reduced. And it's a sub-threshold micropulse laser treatment has also come, which has less of the damage for grid photocoagulation like and others. It is a very, very safe and cheap technique, and it leaves the retinal cells intact. So therefore the damage done is not there, and the field effects also don't appear. So this is the conventional laser wherein the heat is produced and the time taken is more. And here you have the intensity which is produced, and then it cools off, then again the intensity, then so the damage caused becomes too less. The complications of, as I have already mentioned, need not mention again, and it can lead to macular edema in some of the patients. It can also lead to hemorrhage if you have, by the way, hit the veins, because arteries, they get narrow if you hit it, but veins, if you directly hit, then it can lead to bleeding there also in some cases. Choroidal effusion can also occur if you are doing too much of shots are being given. Color vision alterations can occur after the laser photocoagulation, and visual field defects we have already discussed. So these things can occur. So this is short pulse laser is 810 nanometer, which is used for doing the treatment for modified grid I have already mentioned. And there is another laser which has come up these days, which is called navigated laser, in which you have a fundus fluorescein angiography available to you, and you know that these are the leaking microaneurysms. Here we have to do laser photocoagulation, so it navigates, and based on that it does the laser photocoagulation. So this allows us to pre-plan the areas with automatic aim is there, so you don't need to bother, so damage cost becomes much less, and in DME it's very useful. So these are some of the changes that have occurred from conventional laser to micropulse laser to Pascal laser to this navigated laser, and further these young specialists and Professor Shrikant will be discussing. Thank you so much.
I think Professor Kamalji has very well elaborated the basics of laser. It's very important once you are dwelling into the field of laser photocoagulation, you must know what are the laser facilities available for which you can be, for what are the diseases where you can utilize these facilities. With this, Misha is ready. Should we ask the question? The end of it, let the subject be a bit more clearer, then it will be better if you ask the question. दिवाकांत का तो नहीं है, दिवाकांत का तो नहीं है, इंट्रोड्यूस कर दो।
Own son, sir is saying that I introduce him. Sir is sir का भतीजा है, हमारा बेटा है प्रणव सलूजा. So he has done Vitreoretinal fellowship and he's done MS and then senior residency from RIO Allahabad, and now he's consultant at Chitrakoot Vitreoretinal surgeon. They do only vitreoretinal surgery they forget cataract. So, Dr. Pranav Saluja for you.
Thank you. So I'll be speaking upon branch retinal vein occlusion, the studies and protocols of laser techniques, and how to proceed with them. So BRVO has a prevalence of around 4.42 per 1,000, and it can be further classified as major BRVO and macular BRVO. Major is mainly when an occlusion of a retinal vein that drains one of the quadrants occur, and macular BRVO is when an occlusion of a venule within the macula occurs. So the common sites of retinal vein occlusion, as we can see, that usually CRVO occurs where at the central retinal vein, where the vein exits the eye, and the yellow arrow depicts where the BRVO occurs, and it is usually at the arteriovenous crossing, which is a typical site for BRVO. So the causes of vision loss in branch retinal vein occlusion is mainly macular edema, and a long-standing macular edema can lead to epiloid zone loss, and that may lead to loss of vision. The other causes are usually intraretinal hemorrhages. When they are present at the macula, that may also cause vision loss. And this is a mid-phase showing superiotemporal BRVO with block fluorescence of the hemorrhages, and significant ischemia can be seen also. But this is mainly because of the hemorrhage rather than the ischemia. Then the next other causes are ischemia and neovascularization. We can see that there is neovascularization of the disc, and capillary non-perfusion areas can be seen with lots of vascular leakage. And we can also see a vein which shows a block, and there is differential filling in the upper quadrant. So this signifies that it is a superiotemporal BRVO, and there is lots of ischemia in these cases. And this patient would be subjected to laser photocoagulation, mainly sectoral. So it can be ischemic or non-ischemic. Ischemic obviously is worse for the visual acuity, and non-ischemic we can observe also in these cases if there is not significant macular edema. These are the fundus photographs which are depicting fluorescent angiography showing BRVO with macular ischemia. We can see that the FAZ is distorted and it is enlarged. And another photograph which shows peripheral ischemia, but there is no neovascularization in these cases. So we'll be going ahead with the studies that has been conducted for branch retinal vein occlusion. So mainly BBOS was the largest study that was conducted for branch retinal vein occlusion, and they said that greater than 5 disc diameters of non-perfusion may lead to more chances of neovascularization in these cases. A recent study done by Vibrant group has suggested that greater than 10 disc areas has significant chances of development of neovascularization. So in the pathogenesis, we can see that mainly, as we've talked about, that it mainly occurs at the arteriovenous crossing. And in older patients, there is arteriosclerosis, which may lead to thickening of the arterial wall, and this may lead to development of BRVO. This mainly occurs due to compression and obstruction of the adjacent thin walled veins, and according to the virtuous triad, which means that in a hypercoagulable state may occur when there is vessel damage, there is stasis, and then following thrombosis. So complications, as we talked about, is neovascularization. After neovascularization, if it is not treated properly, then it may lead to vitreous hemorrhage, which may also lead to loss of vision. But this is mainly in long-standing cases. And these are the characteristics of a long-standing BRVO. There is venous sheathing, there is neovascularization. Collaterals develop usually in the later phases, and there may be neovascularization, as we've talked about. So the treatment focuses mainly on reducing the cystoid macular edema, preventing neovascularization, and treating neovascularization to reduce the risk of vitreous hemorrhage. The branch retinal vein occlusion study mainly answered 3 questions on the effectiveness of laser. The first one was that can scatter laser photocoagulation prevent the development of neovascularization secondary to branch retinal vein occlusion. Then the second was that can scatter laser photocoagulation prevent vitreous hemorrhage following retinal neovascularization. And the third one was can macular grade laser photocoagulation improve the visual acuity in eyes with severe vision degradation due to macular edema. So it was a multi-center prospective random RCT, and the treatment groups were mainly sector laser photocoagulation and no laser done for non-ischemic or ischemic BRVO. And the conclusion was that the treated eyes were more likely to gain 2 lines of visual acuity, but this was seen more in the patients where there was development of neovascularization. So they concluded that photocoagulation reduces the occurrence of vitreous hemorrhage, but only when neovascularization is present. So we should always go ahead with scatter laser only when there is neovascularization. The other things that were seen was that the visual outcome with the laser treatment was better. That was 60% of the patients had better visual acuity, and in the average visual acuity at 3 years was better in the patients where laser treatment was given. So then the other study was the SCORE trial. This was a trial done in which triamcinolone acetate intravitreal injections were compared, 1 mg or 4 mg, with grid pattern laser for branch retinal vein occlusion. And they suggested that there was no significant differences between the treatment groups when comparing the visual acuity improvement. And the corticosteroid treatment features a worse side effect profile, as in cataract and glaucomas were seen more in these patients. So again, the visual acuity was almost similar in all the groups, and there were more adverse events in these cases. So when to do sectoral scatter photocoagulation, that is mainly when the ischemia develops and rubeosis and retinal neovascularization develops. What happens is mainly the mechanism is that it reduces the oxygen demand by destroying the photoreceptors within the retina, and hypoxia is corrected and production of cytokines is normalized. The laser is mainly directed at the quadrant of the ischemia. So we can see that if there is ischemia in this quadrant, in the superior temporal quadrant, then we usually laser on that side. The recent advances that we do is usually do targeted photocoagulation rather than random photocoagulation. And that can be done after doing a good fundus fluorescent angiography, by which we can delineate the areas to laser. So this prevents the development of neovascularization and prevents vitreous hemorrhage in patients with neovascularization, as B was stated. So the parameters are usually, the size we take is usually 200 to 500 μm size, and the duration is 0.1 to 0.2 seconds. The power is usually medium wide runs, and the laser spots are applied around the posterior pole extending anterior to equator on the ischemic areas. And we usually laser till the ora serrata, because all the ischemic areas, as we've seen, can be in the periphery also. And we usually do a 1 burn apart lasers, and a total of 1200 to 2500 spots are given. The complications that can occur are usually choroidal hemorrhage, epiretinal membrane formation can occur. There can be an accidental burn to the fovea, so we should be extra careful in these cases. Macular edema is another complication that can occur, and there may be formation of CNVM in these cases if we do a very high powered laser. So we should follow up these patients every 4 months, and FFA is a must in the first follow up, because there are higher chances of development of neovascularization at 4 months. And if the neovascularization persists, scatter laser may be added even after doing the first laser. So FFA may be helpful in adding laser during this phase. And the CVOS also stated that the prophylactic PRP does not prevent iris or angle neovascularization. So only in active neovascular disease we should do a PRP. And in cases when a close follow-up is not possible or seems unlikely, only in those cases we can go ahead with prophylactic laser. So the indications of macular grade laser, the duration of at least 3 months we wait, and the visual acuity, if it is 612 or worse and without significant macular hemorrhage. And in cases where the FFA is showing capillary perfusion, we go ahead with macular grade laser. So it mainly improves the tight junctions of the retinal pigment epithelium, and this was demonstrated by the BVOS. And if it is applied in a grid across the macula avoiding the fovea, 50 to 100 μm spot size is taken, and 20 to 100 applications are given. And it can be guided by the FFA, but we can see where the leaking capillaries are present. And within 500 to 3000 micron of the foveal center, we can do macular grid laser. So the contraindications again is if there is macular ischemia, we should avoid laser in these cases and should not be applied over the areas of hemorrhages and intense pigmentation that could cause photocoagulation of photoreceptors in these cases. So the new development is micropulse laser, and in this we can also do lasers in cases where there is hemorrhage already. And there have been multiple studies which have shown very good results with micropulse laser. We do 100 to 300 milliseconds of burst of pulses and of 0.1 to 0.3 millisecond duration. And the power is set below the clinically detectable tissue damage, so we cannot see the spots, and usually it is barely visible. And we follow up the patient after 1 month and see whether the macular edema has improved in these cases or not. If it has not improved, we can repeat the laser also in these cases. So the grid laser may extend up to the border of the FAZ and from arcade to arcade, and the burns are mainly applied over the capillary leaks, and it can also be done over the papillomacular bundle, but it is better to avoid it. And the complications again, epiretinal membrane formation and accidental treatment to the fovea, and there may be visual field effects in these cases. That is why we recently prefer anti-VEGFs or steroids. So the role of subthreshold laser, as we've talked about, it delivers more energy to the RP cells without the collateral damage to the neurosensory retina. And the laser energy is delivered in pulses of on and off laser period. Off period allows the tissue to cool off, and hence more energy can be delivered to the targeted tissue. And it may be as effective as conventional therapy, and recent studies have suggested that it has given very good results in these cases. And because there is no visible laser burn, it may be difficult to titrate the treatment with micropulse, but we can do a combined treatment with anti-VEGF and do a micropulse laser, and that has shown very good results recently. So baseline, if the visual acuity is worse than 612, we can observe and wait for laser for 3 months. We can give anti-VEGFs in these cases, and if the macular edema improves, then we can follow up the patient. But if the macular edema does not improve even after 3 months of observation, then we can go for macular grid laser. And if it is worse with macular edema and hemorrhages are masking, we should do a FFA, which is very necessary after 4 months of follow-up at least. We should see for macular ischemia so that we can decide whether the laser should be done or not in these cases. And if there is macular ischemia, it is better to go with anti-VEGF or intravitreal steroids. And in severe macular ischemia, we have no treatment, and we should regularly observe the patient for neovascularization in these cases. And if the neovascularization develops, we go for sectoral laser PRP. So that is it. Thank you.
Thank you, Dr. Pranav. Thanks, Ran. Basically, what you have to remember that when you get a fresh case of BRVO, you look at the retinal hemorrhages, which quadrant is affected. And at that time, you have to rule out the diabetes and blood pressure. Two things are important, and glaucoma also. And then later on, you do a OCT, immediate OCT is done. And the results of anti-VEGF or steroid is very good in BRVO compared to diabetic retinopathy, because that's a chronic process. Here it's acute process, and if you immediately do intravitreal injection, the edema subsides like magic. If you do OCT after 10 days, you will find that the foveal contour has absolutely become normal. So that is one thing which is very, very important in BRVO. Secondly, the angiography should not be done when the hemorrhages are fresh, because you will not get any information by doing angiography. You have to wait for the hemorrhages to resolve. Once they resolve, then you come to know about the non-perfusion, because if the hemorrhage is there, it creates block fluorescence in angiography, and then you cannot know whether the non-perfusion exists or not. Then you measure the non-perfusion also, and its measurement is done by disc diameter. Like in the BRVO study group, it was said that if it is more than 5 disc diameter, then the chances of neovascularization are there, that too in 20 to 30%. So many of these patients, if you simply keep on following, and if the edema is not there, these patients, they improve. And laser has to be done only when the neovascularization has occurred. Dr. Shrikant sir.
I think Dr. Pranav has very well enumerated the various findings of behavior and how to do the laser photocognition in such a situation. And many times you have to combine with the intravitreal injection because both can give better results instead of going all alone, in fact. And yes, that is mentioned that if there's a new vascular, there's a ischemic macular edema there, then laser is of no value. But some books have mentioned that laser should be done to avoid any NVI and NVE, because otherwise this is the only complication left with ischemic macular edema in a case of BRVO, to do the laser photocoagulation just to prevent the NVI or NVA or new vasculation, as you have rightly mentioned, or observe the new vasculation as and when it occurs so that you can prevent the NVI and NVE. However, as far the visual acuity is concerned, not much improvement is there. Would you like to speak about the central retinal vein or Abhishek?
Also, gonioscopy is very important in these
Yes.
cases. Like every 3 months.
Gonioscopy, undilated pupil,
Undilated
because
pupils.
with retinal surgeon or retinal surgeons are in habit of dilating the
Yes.
first to peep into the fundus.
About
Here
the
you have to peep into the angle.
as sir was saying that there was a topic of CRVO with Dr. Abhishek. So what you have to do in CRVO is that the same things are followed. The only thing here is that you have to decide whether it's a ischemic variety or non-ischemic variety, and its decision is taken by the visual acuity. If visual acuity is poor or there are too many hemorrhages in the retina, you say that it's ischemic. Why it has to be classified is because the chances of neovascularization in the iris increase if it is a ischemic variety of CRVO. And there were several studies done by our Sohan Singh Hare. He is a renowned scientist from India who has done lots of work on optic nerve and CRVO. So that can be there.
He is recently expired.
Recently, yes. So now I invite Dr. Jivesh for his talk.
Hello, good afternoon. Discussing the topic of techniques of pan-retinal laser photocoagulation. So these are the most common indications which we know where the PRP is required. First of all is proliferative diabetic retinopathy. Second is CRVO, as discussed, especially ischemic CRVOs. Third is ocular ischemic syndrome with secondary neovascularization, which is seen in older group of patients, or any kind of vasculitis which can be involving either one of the sectors or might be involving whole of the retina. So here are the two basic modes of laser which we know. There is slit lamp laser and laser with your indirect ophthalmoscope. So slit lamp laser further can be done with three different types. One is single spot or the conventional laser. Second is your multi-spot or Pascal laser. The spellings are missing. Third is a navigated laser, which is a slightly more automated form of Pascal laser. I'll show you a small video in the end. And the other variety, which is indirect, is that also we'll discuss further. So here I'm doing a small basic comparison of a single spot conventional laser with a multi-spot Pascal laser. Single spot laser can cause larger collateral damage, whereas multi-spot Pascal laser is more energy efficient. It focuses mainly to the RP and the collateral damage is very less. There is good regression of disease with our conventional laser, is a single spot. Similar regression is seen with Pascal. Now here are two important points. Single spot laser can usually take up to 5 times more. It is more time consuming, can take up to 5 times more as compared to doing a Pascal laser. Single spot laser is also known to cause more pain because it has a deeper penetration and causes more photocoagulation and also thermal damage to the choroid, whereas Pascal laser is increases the comfort of the patient and it is less painful for the patient. Regression is more or less the same. With Pascal, there might be sometimes there might be difficulty, especially in hazy media where you're not able to achieve proper spots. Then you can shift to your single spot laser. Here I'll show you a small video. Audio is working?
Yes.
If you want, I can narrate.
Continue speaking.
Continue speaking, yeah.
Okay. So just one second. I'll just repeat the video. चल रहा क्या अभी? Okay, anyways, I'll narrate what's going on. So here it is, here we are showing a comparison of a single spot and a multi-spot laser. Here they are showing the Pascal laser, which is having a short pulse as compared to the conventional pulse, which covers a lot of area. It damages the choroid, there is a lot of collateral damage as well as there is damage to the inner retina. So you can see on histopathology also, short pulse is causing a less collateral damage as compared to our conventional single spot laser. One second. Yes, there's one more advantage of our Pascal laser, that you can give uniform high efficiency burns with equidistant as compared to the conventional, which you really cannot control your where you're aiming, and it has a lot of more collateral damage as well. So this is the basic technique of slit lamp laser, where you need to use a topical anesthesia to the patient, have good mydriasis. You need to use a coupling agent with your PRP lens. Can be anything, either be CMC or viscoelastic, which we use in our surgeries. Adjust the magnification brightness and adjust the laser parameters. I will discuss laser parameters just shortly. Then as discussed by Pranav, that you should avoid basically any neovascular zone, because that is a site of, it can be a site of active bleeding post laser, also at the time of laser also. So mainly you have to focus on your avascular areas and ischemic areas. So this is a screenshot which has been taken from a Pascal laser. So here are your parameters. First of all, the status, which needs to be ready before your laser. Then your power, for Pascal it is around 400, for conventional laser it is around 200 to 300. Then the spot diameter, which we most commonly use for PRP, is 200 microns. And exposure time is shorter for Pascal lasers. It is around 20 milliseconds as compared to your conventional lasers. It is around 100 to 150 milliseconds. So this is the lens, the Mainster PRP lens by Ocular, which is the most common lens used for our photocoagulation. We need to note that the image magnification of this lens is approximately 0.5. So the laser spot magnification will become 1.96. That is, if you're giving a 200, if you set your parameters to 200 micron, your actual burn on the retina will be approximately 400 microns. Then it gives it gives you 165 degrees of field. So these are some other lenses by Vogue. This equator lens is for especially for your grid laser, and this is similar quadrant aspheric lens is for your pan-retinal laser. So this is an important slide, because we do our pan-retinal photocoagulation in 3 sittings. I have already discussed the pulse duration and the power settings. So first of all, you have to cover the inferior retina. You can cover your nasal retina also along with that. What it will do, in case inadvertently if you hit a neovascular zone which can cause a bleeding, so it will gravitate down and it will remain in your lower quadrant only. But it for your next second or third sittings, it won't fill up the full retina, so you can still follow your PRP2 and PRP3 later on. So that is the logic of starting your PRP inferiorly. So this is a pattern scanning laser. It is a semi-automatic pattern scanning laser photocoagulation system. We already discussed. These points we have discussed. It is a higher efficiency because of low collateral damage. It has reduced time of treatment. Patient comfort is obviously increased because the pain felt by the patient is less. Precision is there, equidistant burns are there, and it has a good reproducibility. This is the second system, LIO. In case of pan-retinal photocoagulation, this is mostly used where we are having a hazy media, especially in dense cataracts, or you already have some amount of vitreous hemorrhage. There you won't be able to finish your laser with your conventional single spot or Pascal. Then you need to bring in the LIO. It has a steep learning curve. Other than that, it is specifically for pan-retinal photocoagulation. It is mainly for the conditions with hazy media. This is a short video where I'll be showing you. This is basically a Pascal simulator. Audio is not working, so I'll keep you follow along. So this is a advanced
in which we can
audio is
see
coming.
multiple
Can
hemorrhages
you increase the
in
sound?
all quadrants. There is extensive exudation
One second.
in the macular area in between the arcades, and we can also see some amount of subhyaloid hemorrhage just beneath the inferior arcade, just taking up some shape. So when we start the laser, we have to first see that the laser is in ready state or standby state. To begin with, it is in standby. You should put it to ready. Power should be adjusted. Normally power up to 300 to 400 is enough. Spot diameter, we'll keep it as 200 microns. Exposure time is 20 millisecond, and we'll use a standard 5x5 grid with one spacing to be.
Here, one spacing means it is keeping a difference of exactly one spot size in between. We can reduce the spacing if we want a more efficient and like a more strong laser in case we already have some amount of vitreous hemorrhage. I'll continue the video.
Begin. So we start in the periphery. We see uniform laser burns which are dirty gray in color. That is the color which we are aiming for. It should not be extensively bright, otherwise it means we are using energy which is more than required.
So we can
Because
change the
this
pattern.
is an extensive disease, we can reduce the spacing also. What it will do, it will give more compact burns, although it might take up more time, but if the patient requires a better coverage, we can do so. For the macular area, we have specific patterns.
Dr.
Like
Pranav
this
had
one.
discussed, these are pre-built patterns which they have for grid laser, which the laser which you have to start basically 750 microns away from your center of the fovea. And
Compare the single spot burns,
now these are
we'll
the single
see
spot burns.
it takes more time and it is not as uniform. We might also have uneven spacing of the burns as well as overlapping of the burns.
That's it.
We'll be giving you a demonstration.
One second. So this is Navilas. It is just a more automated form of your Pascal laser. It is developed. It has been developed around 10 years back. Here you can incorporate. You can take a photograph, incorporate in the machine. It has automatic features that it will avoid hitting the optic disc and the macula, and it has preset patterns which can complete the laser for you. It took up a small video from their site only just to show you. So here you can see the pattern in which the laser has to be followed has already been pre-planned, and you just need to sit there to see it being executed. This is the most advanced form of Pascal laser, I think, which is available till date. Thank you.
Thank you, Dr. Jagdish Singh. I think he has very well covered about the various modes of the lasers available at your rescue. And whatever you wish, in fact, single laser has got advantage. You can go nearer to the macula more precisely, but multiple laser spots can help you to do the things fast. And yes, initially it was thought that laser burn all will not be of equal intensity, because eyeball is not a flat structure, it is a round structure. It's an eyeball. So may not be equal intensity, but now with the advancement of the technology, they are more or less similar, equal powers, instead of worrying about that one will be less power, another will be
Now we have Professor Shrikant would be speaking on
I think we were on to
you.
issue. Other they were.
They are young surgeons are doing great job in UC. Established it, and they are the stalwarts there, and all the leaders of ophthalmology, they follow them today. So they are great people around, and we are so proud of you all. Thank you.
So it's the greatness of the seniors that has allowed us to function. Thank you so much, sir. I'll be talking about prophylactic lasers for certain predisposing lesions which lead to retinal detachment. So why this presentation? We do not want to land up our patients in a situation like this because we missed something like this. And specifically now the world is under a myopic pandemic, and it is the expected myopes are around 5 billion by the year 2050. And greater number of these people are opting for spectacle removals. But most of them, a lot of patients that we counsel, they feel that their myopia is gone after a laser has been done. But the eye still remains myopic, and the degenerations and all the complications that comes with myopia are still there. And now, there's a study that showed that around 53% of these myopes, they had some sort of peripheral retinal degenerations that were found. Now, retinal detachment has an approximate incidence of 1 in 10,000 people with various predisposing factors like myopia, complicated surgeries, trauma, but we'll be focusing, of course, today on peripheral retinal degenerations. Now, there are a lot of peripheral retinal degenerations that are there. We don't need to know about all of them. We will just focus on the predisposing lesions that can lead to detachment in our patients. So number one, and the most commonly that is found in our practice, is lattice degeneration. Its incidence is approximately around 6 to 10%. The important thing is that only 2.8% of these lattices cause RD. But an even more important statistics is that 30% RDs are associated with an lattice degeneration in these eyes. So others, certain predisposing lesions like snail tract degenerations, degenerative retinoschisis, cystic and zonular tractional retinal tufts, a retinal tear and retinal hole. These are the conditions that might require treatment and consistent and long-term follow-ups. A very important event that occurs is of posterior vitreous detachment. Now, this is something that is like a connecting link between a predisposing lesion and a retinal detachment. Now, which can lead to tears at the sites of the firm vitreoretinal adhesions that are there, and especially in these lesions like lattices and CRTs, and which of course gives liquefied vitreous access to the brakes and thus can lead to it leads to the subretinal space and can lead to a detachment. Now, 10 to 15% patients with an acute symptomatic PVD, people having floaters and other things, are found to have a retinal tear. But when you see blood pigments, you see vitreous hemorrhage, you see other pigments, then the risk shoots up to approximately 70%. Now, it's very important to closely follow up all our PVD cases. Basically, all the patients that come to you with sudden onset floaters and other flashes and other symptoms. And if there is a fresh vitreous hemorrhage and you cannot identify the etiology, the underlying etiology, then these should be kept under very close follow-ups with serial ultrasounds and keep examining the patient till the vitreous hemorrhage clears. Because usually there is an underlying tear, avulsion of blood vessels, which leads to the vitreous hemorrhage. Now, the most important aspect is the management of these cases. Before we start managing, we need to screen these patients and identify the relevant lesions that are there. For this, nothing beats the cost-effective indirect ophthalmoscopy. A lot of the residents that we meet and interact, they're not very proficient with this art, and all of us as ophthalmologists, as comprehensive ophthalmologists, should be proficient in this. Now, of course, we have wide field imaging like optos that are there, but they're expensive, and all of us do not have exposure to these machines. Another pillar of identifying these lesions is a dilated exam. In our center, in my center, we do it for all our patients unless it is contraindicated. But certain conditions, you should always dilate these patients and insist a dilatation. All myopes, one-eyed patients, if there is a history of detachment in the other eye, if there's a family history of retinal detachment, if you're planning any intraocular surgery, be it cataract surgery, refractive surgery, even if you are planning a capsulotomy for these patients, then do a dilated exam. And of course, trauma patients, and definitely patients with sudden flashes and floaters. So this is a very nice article in IGO that came out in 2022 by Dr. Venkatesh and his group about the recommendations. So earlier to this, there were not very clear-cut guidelines that were there. So this article has laid out these guidelines. So peripheral retinal degenerations that need to be considered for treatment. So number one is lattice degeneration with retinal hole, presence of Horst-2 tears or retinal dialysis, presence of retinal hole with a cuff of fluid surrounding it, and traumatic retinal breaks. So these are very important. All of you, this definitely needs treatment. Now, if you see a predisposing lesion in a patient and he has these other associated symptoms like recent onset of flashes or floaters or a PVD, patient is undergoing any surgery, a history of retinal detachment in the other eye, one-eyed patients, and also syndromic patients. If you can spot a Marfan or a Stickler syndrome, then these might need treatment. Now, there are certain additional considerations. If there is a family history of RD, if this means that if there is a predisposing lesion and the patient has a family history of RD, then if the patient is unable to access care or access to retina specialist, and if you feel that the patient will not be in a good follow-up with you, and mentally challenged patients. So you can consider treating these patients. Now, which patients can be safely observed? An asymptomatic lattice. If you see a lattice, there is no hole, there is no symptom associated with it, we can, for all practical purposes, safely observe this case. A lattice with no break or hole can be observed. Pigmented lattices with no breaks and holes, and lattices with even atrophic holes can be safely observed. Now, again, all these cases will need a very good follow-up, and the duration of follow-up is not set out clearly, but I feel at least I do that twice a year, 6 monthly, I try to observe these patients. Now, the same paper had given certain guidelines for a patient undergoing intraocular surgery. So do a dilated retinal exam. If you see a peripheral retinal degeneration which is predisposing to RRD, which we have discussed, treat that patient before the surgery and then plan the procedure at least 2 weeks after this procedure. So there's a lot of confusion regarding after how much time can we operate these patients. So a fair amount would be around 2 weeks. And then, according to this guideline, a retinal examination is only needed if patient becomes symptomatic, if there are flashes or floaters or anything. Now, if there are no such lesions, then you can go ahead and plan the procedure and examination only if the patient develops a symptom. Now, coming to the treatment part, barrage laser as we call it, now it has proven effective through various studies that, like this paper where the other eye of GRT patients was treated. So the incidence decreased from 43% to 13%, and the macular involvement from 17 to 1.3%. So these are definitely effective. There's another paper which studied the patients undergoing LASIK. So they reported a very low incidence of RD in the patients who had undergone prophylactic barrage laser, which was almost 0.25%. So the equipments, how this barrage laser works, so it generates a stiff chorioretinal adhesion surrounding the lattice. It is considered that the strength increases up to approximately 4 times of normal retina, which helps us in countering the traction that might be there and prevents the fluid vitreous from entering the subretinal space and leading to a retinal detachment. Now, the delivery methods, as Dr. Jitesh has discussed, could be slit lamp or a laser LIO. Now, slit lamp has its own advantages. I feel it's very ergonomically better. Nowadays, I try to do all my, but even barrage lasers with the help of a slit lamp delivery system. You have better stability and control, and if you have a multi-spot laser, then it will take lesser time. But there are certain conditions where you cannot avoid LIO. Uh, if you have a very peripheral or an anterior lesion where your these lenses will not help you to reach, there are lesions which require indentation, children who are under sedation, patients who have recently undergone surgery where you do not want to put a contact lens. And another indication could be when you're traveling, you're visiting other centers and trying to laser, then it's difficult to carry your slit lamp. Now, laser settings are pretty basic. It's around, the spot size could be 200 to 500 microns. Power is 100 to 300 milliwatts, and the duration is around 50 to 300 milliseconds. Now, power will mostly depend on the media clarity. Now, important thing to understand is that at the same energy levels, the shorter duration pulses will cause less pain to the patients. So, and the laser will spread less and less collateral damage will be there. Coming to how we do these lasers, at least 2 to 3 burns covering all the margins of the break should be applied. You can go for more if you feel the lesion is bigger and the chance there's a lot of SRF that is covering. It is very important to cover. Before covering, it's very important to visualize the anterior margin of the break and then cover it appropriately. The covering the edges is also very important. If it is not possible to visualize, then one option is that you can cover it till the aura in that part of the eye and indent if you have difficulty in visualizing it, or you can go for a cryo as well. Now, what kind of spots would we like? As Dr. Jivtesh had mentioned, moderately white laser spots would do. Begin with faint white reaction initially. So the full reaction takes certain time to develop, and it will becomes fairly dense after certain time. Now, what if we do it very extensively, at very high power? Then there could be hemorrhages that could develop. It can lead to certain traction that can develop near the tear. It is more painful, it can cause more inflammation and chances of more ERM. If you're lasering a very small hole, then it might not be there, but if you're going for a 360 laser in patients, then it could lead to ERM formation. So if you have a too intense white burn is there, then you can also treat that as a lesion because that area becomes weak and surround it with low intensity spots. Now, follow-up of these patients, as I just previously mentioned, these adhesive poses increases over period from few days up to 2 weeks. So whatever surgery or procedure you are planning, there should at least be a gap of 14 days between the two procedures. So another thing is, after the procedure, after this 2 weeks, what should be the follow-up of this patient? So technically you do not need very regular follow-up once you have lasered, but at least if there are any recent onset symptoms are there, then follow up the patient or maintain the patient in an annual or a biannual follow-up. To conclude, dilated exam with indirect ophthalmoscopy should be for all our patients at least once in their lives and is must for the condition that I had mentioned. You should be able to identify these predisposing lesions. It's very important to counsel these patients because what I felt in my practice, there are certain lesions which you can demonstrate to the patient. But this is one lesion which at times you might not be able to demonstrate if you don't have an optos or something. So I try to document these lesions with the help of the 20D lens and my camera. Once the patient sees that lesion, he gets convinced very easily. It's not about the financial aspect of it, but the patient feels that the eyes are normal. There's nothing wrong with the eye and the laser is being advised unnecessarily. It's very important to educate your patients about the symptoms of PVD or a retinal detachment, and it's very important to document that you have counseled these patients with this. Promptly treat where it is required and follow as per the advice. And I personally feel if you have a doubt whether it is a predisposing lesion or not, it is better to go ahead and treat it rather than to be in a confusion. And if a lot of confusion is there, don't hesitate to refer to your retina colleague. Thank you so much.
Thank you, doctor. You have very well covered about the prophylaxis of the various predisposing lesions of retina. especially the retinal degenerative changes in fact. I think last but not the least.
Now we have Professor Shrikant. He did his MBBS from KG Medical College, and then he did his MS from Allahabad, and he did his retina fellowship under Professor Nagpal, and worked in BHU for quite a long time. He was professor and head there, and he has now his own clinic, and his daughter is also working with him. So she's a cornea specialist. So we are passing on whatever we have little to our next generation. So Professor Shrikant is one of the few retinal surgeons who started doing retina in Uttar Pradesh. So his experience is quite vast, and you will learn a lot from him, Dr. Shrikant sir. And about this prophylactic laser, I would say that at times you have to be careful about doing laser photocoagulation, in the sense that when you have fluid, the laser would not work. If the detachment is there around the tear, it would not work. So then, as Dr. Deva had said, you have to do cryo application there in the peripheral areas. And in the past, it was the only thing available to us, and we used to do cryo application then. So if the fluid is there, you straight away go ahead and do cryo. Dr. Shrikant sir.
I think in the end it's very important the follow up these cases. It's not as if you get married after first very date. Laser is a continuous process where lot many datings are required. So you must call the patients for follow up regularly, not as if after one go you are very happy, his laser is done and keep him up. The follow up of the history and examination should be history of the visual symptoms. That's very important because many prophylactic you did for the lasers or predisposing retinal degenerative changes may land up sometimes a true retinal detachment. In fact, I have seen few cases where the patient was having a retinal degenerative changes. We were predisposing the retinal detachments. You did the laser and patient developed the retinal detachments. So that is also important. Devakanda very rightly mentioned. There the risk also involved with that also, but you must evaluate risk and benefits and be prepared for the benefits to be given to the patients, not as if for risk or fear of the risk you are not doing the benefit of the laser photocoagulation. As for this topic was for tips and tricks for the general ophthalmologists who were tackling the medical retina, especially the diabetic retinopathy, which is coming like an epidemic in fact. So not only you have to do that is diabetic workup, you have to look for the duration of the diabetes, glycosylated hemoglobin, that should also be controlled in a follow-up period by you, diastolic blood pressure, blood profile. These are few of the things which are more causing the changes of diabetic retinopathy if it is not well controlled. Follow-up examination regularly, you must look for the visual acuity as measurement as many times. The new escalation, IE and new escalation in angle can develop angle closure glaucoma, or glaucoma may develop and patient may lose the vision because of the glaucomatous ophthalmopathy because you didn't follow up these patients for the NVI and NVA. Slit lamp biomicroscopy is very important. Gonioscopy, yes, very important. I mentioned initially, we as a vitreoretinal surgeons are in habit of dilating the pupil, but yes, gonioscopy, before dilating the pupil, you look for the angle, whether any new vascularization in the angle is there or not. And undoubtedly, the fundus with full mydriasis should be evaluated so that you can look into the periphery where more of microhemorrhages are there in the periphery. Fundus evaluation, everybody has most of people have covered it by the non-mydriatic rectal fundus, but I prefer cumbersome, although it is developed by the Skippens and Putterman. Putterman was a physicist attached with Skippens, a father of indirect ophthalmoscopy. Once he is a high myopic person. Once he was asked to get his retina evaluated. That's also very important story, in fact, that he could not get his eye examined, but instead of keeping mum, he was working in retina shade with Skippens, who happened to be the father of indirect ophthalmoscope, handheld indirect ophthalmoscope. Instead of sitting mum, he worked on this and then developed an indirect ophthalmoscope, which is called a small pupil indirect ophthalmoscope. In actually, it was a Skippens Putterman, because it was difficult to speak the Skippens Putterman. It is commonly called as a small pupil micros indirect ophthalmoscope, where instead of dilating the pupil, you can see through that only. And I was lucky enough to see this developing in way back 87. Once I was there in that very center. Yeah, undoubtedly, 3-mirror contact lenses are the choice as far the surgeons are concerned, and 90D and 76 have come to the rescue of vitreoretinal surgeons, that without putting up any contact material, you can use a non-contact type of lenses. That's another very, very important thing, record keeping. Dr. Everybody has mentioned about the importance of record keeping. It's important. So evaluate the case, whether what exactly the lesions are there, where exactly these lesions are there, so that you can treat them properly and look for the any additional lesions if developed at all. That's another thing that many times you want that things should be with you or your staff only, not to be given to the patients, that how many sittings you have done or so. So one can use, instead of 1, 2, 3, 4, where the patient comes to know, you can use the alpha, beta, gamma, and delta and epsilon. These are the mnemonics you can use for the sittings which you have used, and thus you know itself, this was the first time, this was the second time, this was the third time, fourth time. This really carries a meaning, in fact, because if some new lasers are done, you must know whether it was your last sitting or first sitting or third sitting or whatever it is. As I mentioned, that treatment varies. ICU has come with the guidelines. Kamalji has also mentioned earlier, in fact, guidelines that you have to treat as per depending upon your setup, in fact. In high resource findings, where they are having access to the OCT angio, they have described that you must keep the fundus photography, fluorescein angiography, and OCT angiography of these patients for better, proper follow-up of these patients. Optical coherence angiography is a new device which has come to our rescue for the treatment of these type of cases. The results of treatment, that's very important. The laser photocoagulation should be evaluated, and usually it is evaluated 2 weeks after the laser photocoagulation. A constant follow-up is recommended. That is very important. First in 2 weeks, then 3 to 6 months, and then annually. Additional laser photocoagulation, if new vascularization has occurred, should be done accordingly. The things to look for after retinal laser photocoagulations are maculopathy, formation of macular epiretinal membranes, rhegmatogenous retinal detachment, if any, and exudative retinal detachment. New retinal vessels, early postoperative period, interretinal peripheral hemorrhages and vitreous hemorrhage, and choroidal hemorrhages. Although these are not the common complication, but sometimes the rare complications are there in the form of corneal burns, raised intraocular pressures, and lens autofocusation. They are mainly due to the incorrect focusing of the lasers. As I have already mentioned, that sometimes incorrectly a novice has focused the laser on macula, thus you can have a macular burn. But try to avoid these things, and proper settings will definitely avoid, and with the experience, these things can be very well avoided. Sometimes some of the patients complained of the impaired color visions, not affected by the PRP, but due to focal or grid lasers, macular and peripheral scotomas, visual field loss, as I mentioned that once we are doing PRP, then modest peripheral field reductions is there, and some loss of contrast sensitivity is there. Alarming symptoms is increasing of the, if patient is having alarming symptoms, increasing of the flashes, floaters, pain, redness, significant decrease in the vision, sensation that the field is obscured by the black curtain. These patients should be sincerely evaluated, dilated pupil, and with indentation. Maybe in periphery you may find some irmas or new vascular patients. I think with this, sometimes already covered that sometimes subretinal and vitreous hemorrhage can occur. Retinal detachment, retinal tear is already mentioned. If neovascularization is there, again the laser photocoagulation is there. Just to last but not to mention, just to mention that yes, some treatment, newer treatment modalities are available. That is chemical vitreolysis, Jetria, however, initially introduced with, it's very expensive. But yes, maybe in future it will become more cheaper. And these are coming to our rescues along with the intravitreal injections. As far the treatment of the retinal detachment disorders are concerned, especially the vitreomacular adhesions are there, instead of going for a full-fledged vitrectomy, one can inject the Jetria, that is occuplasmin, and can get a satisfying results to prevent any hard, difficult results or the complications of posterior vitreous adhesions or posterior vitreous detachment. With this, I think we have almost covered all the topics and try to do justice to our allotment or so. But in case any queries is there among the audience, you are welcome for that. Thank you.
In the last, we'll have a photograph with the speakers, and you all can come on. So Dr. Jivtesh, Dr. Divakan, Dr. Pranav, and myself, I thank all of us. Thank you so much.